does the Patient Reported Outcome Information System, or PROMIS Physical Function Scale, perform as well as recommended performance-based tests to identify older adults at falls risk? And this research was primarily done at George Fox University, and it's being used by University of Rochester in helping adapt their prevention program for falls prevention, and that's why the collaborative slides here. So the first point is that falls are not part of aging. And every 20 minutes, an older adult dies of a fall. 1 out of 5 falls causes a serious injury, such as head trauma or fracture. Less than half of Medicare beneficiaries who fell in the previous year talked to their healthcare provider about it. And more than 3 million older adults are treated in emergency departments for non-fatal fall injuries. Medicare costs for falling injuries total over $31 billion annually. And all of those statistics emphasize impact, but this graph here is what is most alarming in terms of like fall death rates in the US. And you can see here's annual since 2007, and here's the rates, and they're progressively increasing. And so arresting this or mitigating this increase is the goal of this Center for Disease Control and their new kind of proposed programs. And essentially the Center for Disease Control has emphasized some action to try to prevent falls, mostly because there are some modifiable variables that are possible to implement. These are motivated by the Otago program, which has been embraced by the National Council on Aging as an example of a scalable program that can be used to at least try to impact this fall rate. And essentially there's many different modalities that are similar to the Otago program, essentially Tai Chi as an example, and other exercise-based modalities. And so they can either be delivered in a community or a PT delivered program, and in particular the Otago resulted in a 46% decrease in falls and fall-related injury. So essentially they're looking for scalable versions of the falls prevention programs which are valid, that can either be delivered in the home, outpatient clinic, community setting, and these involve exercise. They can be independent, class-oriented, or online or virtual applications. And they also can be delivered by a PT or PTA, which has some Medicare reimbursement available, and with the caveat that they have to participate in at least an 8-week kind of exercise program. And there's more parameters and details around this at the National Council for Aging, and then different online versions of the Otago program. And the idea that these programs should focus on improvements in functional measure, perception of ability to sit, to stand, kneel, and walk, and improvements in balance, confidence, and fear of falling. So it's worth it here just to see what the Center for Disease Control has evolved in terms of a possible prevention program. And the acronym for this is STEADY, which stands for Stop Elderly Accidents and Deaths Due to Injury, and involves essentially 3 components of this algorithm, right? So the first component is screening. So some kind of screening test that catches people who are potentially at risk, and essentially that comes down to asking questions about falling, and then using patient-reported outcomes or something like the PROMIS to identify them. Those are possibilities for screening. And then essentially once they've screened positive, then we would use physical tests to confirm that they have weakness or balance deficits that could be remediated with exercise. And then the third element is if they've had falls, what was the consequence of those falls? So if they're having multiple falls, or if they've had an injurious fall, well then that's a sign that the fall is more significant than an inconsequential fall. And so in terms of implementing this across a health system, the first step, and potentially one of the most important is this kind of screening test to get the size of the problem in terms of the number of visits and number of necessary confirmation tests down to a smaller level, is the accuracy of this screening test. And so the PROMIS Physical Function Scale hasn't been used as screening. The Center for Disease Control and in the study algorithm, they have their own kind of scale that they've used, and their own kind of individual question. And so part of implementing this would be an attempt to try to use the PROMIS Physical Function Scale as an alert rather than this unique scale by the CDC, because it's widely applied across the health system. And so the question for this kind of focused research is, how does the PROMIS Physical Function Score kind of line up just with the study categories of risk and confirmation tests that have been recommended by the Center for Disease Control in the study program. So we have two data sets. So sample one is here, community dwelling elderly volunteers, and these patients all had chronic illnesses but didn't have an acute episode of anything at the time of the data collection. It's a fairly small sample of 50 participants with an average age of 77.1 years, predominantly female, and the number of fallers in this group that had fallen at least once within the past year was 10, so relatively small amount. These elders were administered something called the Modified Physical Performance Test, which includes a 5-time sit-to-stand, timed stair climbing, and gait speed, in addition to the PROMIS Physical Function Scale. And this is the receiver-operator curve, which we see here as the sensitivity on the y-axis and 1 minus specificity on the x. And this essentially asks the question, how accurate are these scales in picking out the 10 patients who were fallers among the 50. And what we can see is the dark blue line is the PROMIS scale, and the dotted lines are the physical performance tests. And in this case, visually you can tell that the PROMIS Physical Function Scale performed as well as the physical performance tests. And here's the area under the curve, which quantifies their accuracy across all the different possible thresholds. And we can see here is that the area under the curve is actually the highest for the PROMIS Physical Function Test. So this is a kind of pilot data which supports the idea that the PROMIS Physical Function Test may be a good screening tool for identifying patients at risk for falling. And what we can see here is that for this data set, it's a little bit larger, 120 participants. All of these community dwelling elders were participating in an exercise program, and that's how they were recruited. Their average age was a little bit younger than the previous sample, higher percentage of females, using a frailty scale. About 10% were frail and 30% pre-frail. The number of fallers with one or more falls was 36.7%. And the other data points that were collected were the PROMIS Physical Function, the study criteria. So we administered the study criteria so we could determine whether the PROMIS Physical Function Scale kind of lined up with the study categorizations of minimal, moderate, and high risk for falls. And then we also administered a scale that has known validity for predicting falls, which is the falls efficacy scale. And then we looked at their kind of falls history. So here's the confirmation tests that are recommended by the study program to identify or confirm somebody who's been screened positive at risk for either functional deficits with the timed up and go, kind of balance deficits with a 4-stage balance test, and then strength deficits with the 30-second sit-to-stand test. And so essentially the thresholds for the timed up and go were 12 seconds, ability to hold the 4-stage balance test past the second stage were confirmed that they're not at risk, and then a normal reading and for the 30-second sit-to-stand test compared to normative data would indicate that their strength was sufficient. And so if we look at the profile of this particular 120 participants, we see that about 37% fell at least once in the last year, and then the number of kind of abnormal tests on the tug, 30-second sit-to-stand, and four-stage balance test varied between around 15% to 25%. So in determining fall risk, the study program recommends that the person answers that they feel like they're at fall risk, or that they are administered a questionnaire that identifies them at falls risk. And then they test positive for at least one of the physical tests that we described. If they test positive for both of those, then they're at moderate risk. In addition, if their falls history suggests that they're repeat faller or that they've injured themselves for falling, they would be classified as high risk instead of just moderate risk. So here we're looking at the ability of the PROMIS physical function tests and then the kind of competing falls efficacy scale, which has also been identified as a patient-reported outcome that can distinguish fallers. And so on the receiver operator curves, where we see the sensitivity here on the Y and the 1- specificity on the X. And so essentially the moderate and high risk, so this is the first assessment is the ability of both of these scales to identify people at above minimal risk for falling on the study criteria, and that's in the dotted lines, with the dark blue being the PROMIS physical function scale and the red being the falls efficacy scale. And we can see that in this particular case, the 20 patients classified as at moderate or high risk were clearly better identified by the falls efficacy scale as compared to the PROMIS physical function. When we categorized patients, though, as only at high risk, so here we have 13 at high risk, and there in the solid lines, it was a little bit more positive in terms of the physical function test. Essentially, the area under the curve, you can see visually here that the curves kind of overlap a little bit in terms of the solid lines for the falls efficacy and the PROMIS physical function. And then when we look here to the right in the table and we examine the area under the curve, which kind of gives us this overall quantification of the accuracy of the tests, we see that the PROMIS physical function test now is above 0.7, slightly below the falls efficacy scale still, but in the range now of clinically useful. So anything above a 0.7 is considered moderately accurate in terms of the area under the curve. Now, when we, instead of looking at how the patients were classified by the study criteria, if we look at the actual physical tests that were used and the ability of both the PROMIS physical function test and the falls efficacy scale to identify patients that were either below threshold on the tug or 30 abnormal on the 30-second sit-to-stand, or couldn't perform stage 3 or 4 of the four-stage balance, or positive on any of these 3 scales, the outlook's different in terms of how the physical performance test performs. And so essentially here, the area under the curve for the tug is superior to that of the falls efficacy scale, and abnormal tests for the 30-second to sit-to-stand, it's also better. And then, however, for the four-stage balance test, it's slightly lower, and then positive on any of them, the falls efficacy scales is a little bit better. But essentially what we're seeing here is that in terms of identifying physical disability or problems, the PROMIS physical function test performs at least as good or better than the falls efficacy scale. So a little bit of disconnect between identifying fallers and then physical problems from the PROMIS physical function test. So here we produced a table of the different possible thresholds that could be evolved from those receiver operator curves for the PROMIS physical function test. Essentially, we looked at three different thresholds that it performed well with, and that was the tug 12-second threshold, and then the any positive test that was nearly an AUC of 80, and then for high-risk individuals according to the study protocol. And if we look at the three ways of identifying a threshold, so they're represented here, and they're like the shortest distance. Here we have the thresholds identified by an 80% sensitivity, and then here the thresholds identified by 80% specificity. And just, rather than go through the ins and outs of each individual approach to identifying the threshold, notice that the range of the thresholds is not very high. So for even the shortest distance here, we have like 42 to 44. For the sensitivity criteria, it's up to maybe a 46. And then for the 80% specificity, we're lowest thresholds around a 40. So I think it would be safe to say that thresholds between like 40 and 46 are going to be within the range that people are starting to transition from physical function that's above the level where strength and balance is causing falling, and then below those levels you're starting to get to where people are at more falls risk. So here we've tried to kind of plot this big picture of how physical function on the PROMIS test and their T-scores kind of line up with falling. And we know that the 50 for physical function is the average of the US population. And what we've tried to do here is put the main bucket that we're trying to use to prevent falls is that this identifying people who are approaching strength and balance deficits that place them at falls risk, because those are remediating. You can remediate those with kind of exercise or walking programs and things like that. And so essentially we plotted the thresholds that we identified between like that 40 and 46 number on the PROMIS physical function test. And then we've kind of put here in red the higher fall risk from people who are kind of still mobile but have strength and balance deficits. And we want to contrast those with people who fall just from being active in kind of the normal ins and outs of daily life, right? So essentially there were 23.8% of the 42 fallers in the sample that fell while they were outside. One fell while they were running, another fell from kicking a log while they were hiking. And so these falls may not be remediatable or fixable with this kind of intervention program. But the 42% of these 42 fell during an ADL, 14% tripped over something inconsequential in the house, and then 19% tripped on a stair. And so this, which is over 70% of all the falls, would be potentially able to decrease with a program that focused on strength and balance deficits. So this is the fall rate graph that we started the talk with, and I think the ultimate goal is a public health program that is implemented either through the health system or outside of the health system that can decrease this or mitigate this falls risk. I think what we've reviewed here is an approach where PROMIS physical function scales are calibrated to a level of loss of physical disability where falls risk is starting to emerge as a possibility. And we would propose this as a potential approach to identifying people at falls risk in terms of screening and then following it up with other tests.